Hi there, I'm Dr. Ellie Stein. This is the third of 3 introductory recordings about myalgic encephalomyelitis, chronic fatigue syndrome, ME/CFS. In this short video, I discuss the management strategies for the most common symptoms of the disease. A reminder that this recording has been edited from a teaching video I created for medical students. So in places, I will refer to you as a medical student. Rest assured, the information will be relevant to you whether you are a patient, a caregiver, or a healthcare professional. Again, the take-home message is that this disease is real. What you can do to help your patients is believe them, validate their experience, help them manage their symptoms, and let them know there is hope. Now, if diseases are like puzzles, ME/CFS is the 1,000-piece puzzle. It's very complex, and people come in with a lot of symptoms. Busy clinicians are easily overwhelmed. My recommendation is that you ask your patients to make you a list with their most disabling symptoms, the ones that are bothering them the most. You then let them know that you're going to help them one by one learn how to manage these symptoms to improve their quality of life. Remember that managing symptoms is different from a cure. Just because patients learn to cope better doesn't mean they are better, but nevertheless, it's still very worthwhile. The 5 most common symptoms of this disease are profound fatigue, post-exertional malaise, unrefreshing sleep, and at least one of cognitive impairment and orthostatic intolerance. I'm going to briefly share how to manage each of these symptoms. Remember that ME/CFS is a disorder of decreased cellular energy. Therefore, the most important self-management strategy is pacing. Pacing means teaching patients to adapt their activity level to their energy level. Now, in the past, people have tried the alternative approach, which is graded exercise, pushing patients to gradually increase the amount of activity they do each day, with the mistaken belief that increased activity will increase energy and decrease symptoms. This has proven untrue. Graded exercise makes most patients with ME/CFS worse instead of better. So please, please, please don't recommend it. Pacing looks like this. First strategy is chunking, breaking activities into small enough chunks that people can complete them without exacerbating their symptoms. Then there's switching, moving between different types of activities so that each body system can rest. And then there's outright rest, either preemptively before an activity or restoratively after an activity. Unrefreshing sleep is one of the problems that people complain of the most, because without enough sleep, they don't have the energy to do anything else in their life. And unrefreshing sleep occurs in people who sleep little and people who sleep for hours and hours. Now, the treatment for unrefreshing sleep is cognitive behavior therapy for insomnia. This has 4 components. The first is reconditioning your brain that bed is a place for sleep. In order to accomplish this, patients have to learn not to do activities other than sleep when they're in bed and not to sleep in places other than bed. Secondly, for some people, restricting time in bed is helpful because it helps consolidate and improve the quality of sleep. Calming the autonomic nervous system through simple strategies like paced breathing with a slowed exhale can be very helpful. and helping patients identify anxiety-provoking false sleep beliefs can also be helpful. In addition to this cognitive behavioral strategy, unfortunately, many people with ME/CFS also need sleep medication. This is a controversial recommendation because we know that unfortunately sleep medications have short-term side effects and the potential for long-term side effects. Keep in mind, however, that long periods of unrefreshing sleep also have short and long-term health consequences. To help people decide whether using medication is right for them, please familiarize yourself with the commonly used medications and the potential risks of the medications and of prolonged unrefreshing sleep, and then help them figure out what's the best course of action. The brain uses 20% of the body's energy, so it is impacted as much as the body by insufficient cellular energy. Therefore, the same pacing strategies that I recommended for physical activity also work for mental pacing and decreasing what patients call brain fog. So chunking, switching, and resting before and after cognitive activity is helpful. In this audio clip and the next, real patients describe how they have improved their sleep and energy through self-management.
I am speaking on sleeping and pacing with ME/CFS. Thanks to Dr. Ellie Stein, I learned that it is not important to worry about how much sleep I get because my body will take what it needs. Also very helpful to wind down before going to bed and to get off blue light. And then in the morning, to get up at the same time every day. As far as pacing goes, since activity knocks me down, I just pace myself in chunks of time and I make sure that I have rest time.
I first tried pacing with a grain of salt, just as a seemingly harmless experiment. I started by priming myself for a relatively sustainable pacing trial that included addressing my doubts and questions about pacing objectively, with ongoing addressal of anxiety, self-worth, and setting boundaries without feeling guilty. I targeted just the basic issues first, that is, sleep, nutrition, and daily chores. I found Oura to be helpful in getting serious about and making improvements in my sleep. I break down my chores into chunks now, with rest periods in between, without feeling less about myself. So far, the frequency of my crashes have decreased, as well as the accompanying self-loathing. But most importantly, I'm way more hopeful of having a better future. Thank you for listening.
Orthostatic intolerance is found in as many as half of all patients with ME/CFS, especially in younger patients. We think this is due to a combination of insufficient blood volume and insufficient cellular energy. With insufficient blood volume, there's not enough blood getting to the brain, and this causes the symptoms of OI, which is dizziness, weakness, nausea, fatigue, and the urgent need to sit or lie down. Orthostatic intolerance can be measured with a simple in-office test called the Nassau Lean test. The details of this test can be found on the resource page, but in brief, after a period of lying, the person stands up, leaning back against a wall, and blood pressure and heart rate are measured every minute for 10 minutes. If heart rate goes too high, blood pressure goes too low, or the pulse pressure, the difference between the systolic and the diastolic collapses, this is evidence of orthostatic intolerance. To treat orthostatic intolerance, hydration, oral salt and electrolytes, and medications can be extremely helpful. This is one of the comorbidities which is really important to identify because treating it can help patients feel and function a lot better. Florinef increases blood volume, midodrine is a vasoconstrictor, and beta blockers help calm the increased heart rate that often accompanies orthostatic intolerance. In addition to these core symptoms, there are other symptoms commonly found in ME/CFS, such as chronic widespread pain, endocrine symptoms, the most common of which is difficulty adapting to different temperatures, and immune symptoms, the most common of which is flu-like symptoms and the development of chemical and sensory hypersensitivity. Now, the most common pain type found with ME/CFS is the tiring, aching, large muscle pain of fibromyalgia. But there are other types of pain, as is demonstrated in this evocative image, and they include headache and gastrointestinal pain associated with irritable bowel syndrome. Now, to treat pain in the context of ME/CFS, overall management, including pacing and adequate sleep, are key. Some medications are also helpful, and increasingly, people are experimenting with mind-body strategies to reverse the brain hypersensitivity, which causes persistent pain. Environmental sensitivities, also referred to as multiple chemical sensitivity, occurs in 7 to 12% of adult North Americans, but it's as many as 50% of people with ME/CFS. This disorder can be incredibly disabling because people who have severe environmental sensitivities can't be around people and usually can't show up to workplaces, so they end up unemployed. So what can you do for patients with sensory sensitivity? First and foremost, believe them, because these are real diseases with disabling symptoms. Keep your office scent-free. If you are prescribing or recommending anything to be ingested, start at a quarter or even a tenth of the usual recommended dose and work up very slowly. Just as with persistent pain, people are beginning to think that sensory hypersensitivity may also have a neuroplastic component. And so similar mind-body strategies that help people with persistent pain are also being tried in people with sensory hypersensitivity. Patients often need psychological support. Their lives have been shattered. They have been traumatized, not only by the illness, but by the ripple effects in their life, and also by not being believed by people in their circle and also by healthcare professionals. My goals for patients include helping them accept their present situation, keeping hope alive by sharing information about patients who have improved, and letting them know that I won't abandon them, that I'm very patient, and I will work with them symptom by symptom to improve their quality of life and achieve a better future. Patients know more about these conditions than you do, so listen more than you talk. Ask them about their lived experience so that the recommendations you make are well informed. Ask about suicide. Patients give up hope because they don't see any chance of future improvement, and refer to a mental health professional if needed. In this audio clip, you will hear a holistic, less symptom-directed approach to self-management. People with ME/CFS are all different, and different approaches appeal to and work for different people.
What has helped me most, except from pacing on the physical level, is meditation. And I think meditation has opened up an understanding of healing that is different from what I have my understanding of healing before, that you can heal on other levels than the physical, on the spiritual and your soul level, and that you can kind of also get a break from your depleted body through meditation and feel well-being and wholeness through meditation. That has helped me.
We've discussed some of the common comorbidities that accompany ME/CFS. It's important to ask about these for two reasons. One is, if the common comorbidities are present, it increases your confidence in the diagnostic label. And secondly, some of these can be treated. And so by identifying them, you may be able to significantly help your patient improve their quality of life. Some, like pain, orthostatic intolerance, and hypersensitivity, we've already discussed. There are others, like joint hypermobility, mast cell activation syndrome, irritable bowel syndrome, and more. To find out more about the comorbidities, go to the resource slide. Lastly, patients have important, sometimes life-saving, non-medical needs. Patients need enough money to survive, and in order to accomplish this, they may ask you to fill out forms to support their disability applications. Please help them. Please meet with family and carers so that they know that you take the patient's condition seriously. Help them apply for work and school accommodation. And lastly, if you are working with a patient who's among the 25% who are severely ill, house or bedbound, please help them access needed home care. I asked some of the patients what they would like you to know to better help your future patients with ME. And here's what they said.
Recognize that this is a multi-system disease that severely affects patients mentally, physically, economically, and socially. Believe your patients' testimonies and treat them with respect. They may very well be more informed about the illness than you are. Advocate for them by educating yourself and your colleagues. Be prepared and willing to test off-label and experimental symptom relief. Watch Jennifer Bray's documentary Unrest. Never doubt the integrity of a patient with an illness you failed to diagnose.
The one thing these students should know to be able to later help their patients with this condition is to believe and to validate the patient. This is exceedingly important because patients suffer greatly from not being believed and therefore not being helped.
In addition to the IACFS ME Primer and the US ME/CFS Clinicians Coalition resource page, I introduced two new resources on this slide. Both are recently published peer-reviewed publications, which are open access papers. The first, written by the US ME/CFS Clinicians Coalition, is on the diagnosis and management of ME/CFS. The second is on the care of the severely and very severely ill, those 25% who are house or bedbound. Finally, here are two papers. One is a validation study of the use of the Nassau Lean test to identify orthostatic intolerance in people with ME/CFS. The second paper is a summary of orthostatic tolerance and its treatment by expert Dr. Peter Rowe. Thank you for watching these 3 recordings. I have a lot more information on my website. Please take the time to surf and find what you need.